So what would you like me to do here?
Well, I would like you say, we'll give you maybe 3, 4 minutes, read the story, see the ECG, and then tell me what you think in the ECG. Okay. And
Okay.
we'll discuss it together. Okay. Like you are in the ED and we are together and, we are coming and discussing the ECG with anyone else in the emergency department. Okay,
Okay, no
but the only
problem.
difference that you will be in the setting of the GP. Okay, the patient came to the GP practice having for chest pain. You ask for ECG, okay, and the nurse bring it to you, and then what is in the ECG and what is your next step? Okay,
Yeah, thank
okay,
you.
yeah, no problem. So basically, this case is 60 years old case. Okay, female patient, hypertensive, diabetic type 2, and then came to the clinic with a chest pain, retrosternal chest pain, persistent for 4 hours with radiation, accompanied with nausea, vomiting, palpitation. Her vitals is there. You did examination to the cardiovascular system was normal, and then based on the clinical vignette, you feel that this is a cardiac sounding chest
Just
pain.
me.
You
Mm.
called the ambulance to come and take it, and then ask the nurse to do an ECG. The nurse did the ECG, then she come and tell you, okay, doctor, shall we start the ACA protocol? Shall we give the aspirin? Shall we give GTN? Shall we give morphine if you have, while the ambulance crew coming or not? Okay, and then also was asking you what you think about the ECG. And the other thing that I would also add it here, if you have two hospitals, okay, one have a local hospital, a small hospital doesn't have primary PCI, and the other one, and it's like 20 or 30 minutes away, and the other one is like 1 hour away, but have primary PCI, it's the major hospital for the area. Which one you will be keen to call first, and which one you will say to the ambulance crew to take the patient for to, and why? Okay. Shall we?
Okay.
Yeah, and this is the ECG. No rush, take your time, and we will not start except when you feel confident that you reached the diagnosis and you want to discuss. Okay?
Mm. Okay. So this is actually is so if I see this ECG,
Mhm.
I will ask for the posterior lead as well.
Okay. Yeah, good thinking, but why?
Yeah. For like a, because I can see V1, V2, the lead showing ST depression.
Okay.
So it's usually actually ST elevated MI, posterior MI.
Well, it's good thinking, but it's not. Because usually with the posterior MRI, you will have tall R waves with the ST segment, not deep ST, not deep S wave.
Okay.
Yeah, because so it will be reversed. So you will find the S wave is shorter and the R wave is high, and that the ST segment either, usually will be depressed. Okay. rather than isolated elevation in V1. This is isolated elevation in V1. So even V2, there's not elevation. There's no elevation in it. So a good thinking,
Yeah,
but
uh,
have another goal.
so in that case, so it's actually is anterior MI, anterior lateral MI here. I can
Uh,
see
okay.
lead 1 AVL and
Mm-hmm.
V1 to V5, V6, not very clear, but V6, V5, ST depression.
Okay, so usually MI is mean STEMI, isn't it? So this is non-STEMI or non-STEMI?
Non-STEMI.
Okay, okay. So that will lead us to the other question where you will
No,
send the
ST elevated, ST depressed here. Yes, non-STEMI.
okay.
Yes.
So where you will take where you will send this patient?
So I will
So
send this,
which hospital?
I will send still this patient for PCI for one
Okay.
hour.
Okay.
Yeah,
So why, if it's non-STEMI, why you will send him to PCI?
because patient can patient need actually uh, uh, well, angiogram and to see need any stanting or not.
Yeah, well, for sure, any patient with myocardial infarction or ischemia will need angiogram. But according because we are treating the patient under NHS, so we don't have the capacity for every patient to send him for primary PCI, okay, which is within 1 hour or 3 hours. So there is a chance of sending the patient for delayed PCI, isn't it? So
Yeah,
is that patient you will send him for delayed PCI? So you will send him for the local hospital, stabilizing him, giving him antiplatelet and anticoagulation, and stabilizing him, and then maybe do CT coronary, confirming the diagnosis, doing serial troponin, or you will send him directly and activate the cath lab. So which one you
just
think this?
let me see
Sure.
actually another time
Yeah, sure.
because mm, inferior, it's very subtle. I'm not very
Yeah,
clear.
yeah,
Is
sure,
it
but
a
that's
lead
good.
three?
Yeah, yeah, lead
Lead
three. What's wrong with
three
lead
is
three?
very, very small rise in
Okay.
there.
Well, actually, it's not small rise. It's maybe small picture, but if you can see, so this is the TP segment is here, so you can see the rise is like 1.5 small square, isn't it?
Yeah, 1.5 small
Yeah,
square.
which is for the limb bleeds, it's something big, it's not something with the chest pain especially. Then there is raise, but usually, because the old guidance was saying, okay, if there is an isolated rise in one of the leads, it's not significant usually. Yeah, we usually said, okay, isolated rise in anatomically concordant leads. Okay, and we'll explain what does it mean anatomically concordant leads. Okay, so do you think that's worth sending the patient for doing primary PCI or not?
Yes, I'm still concerned. Like here is a small rise. It's a big rise. Okay, yeah,
Yeah.
1.5. So we'll
No.
send this patient for PCI. So
Okay.
looking at this ECG, I'm not like I still prefer to because it's a ST elevated
Yeah,
lead
yeah,
three
okay.
only. Lead
Yeah, yeah,
three.
which is not anatomically concordant, isn't it? So if the patient have inferior MI, this will be in 2-3 AVF, isn't it?
Yes, 2-3. 2 is depressed.
Okay, so there is something wrong, but we are not sure what is wrong. But is it STEMI or non-STEMI?
STEMI because still one lead is there.
Okay, so let me explain. You are right. Okay, that patient need to go to the primary PCI. Okay, but not because that it's showing what is called previously STEMI. It's a complete occlusion. There is sign of complete occlusion of their coronaries, because what is the difference between STEMI and non-STEMI? So non-STEMI is partial occlusion of the coronary arteries, and that's why we can try with them, giving them antiplatelet on, and then, vasodilators, and then we can have later on delayed coronary stenting. But in the ST segment elevation MI, they find that the coronary arteries are completely occluded, and then there's a life-saving measure that you need to open now the coronary arteries, and that's usually present with ST elevation. Okay, but these now are polished, because also I will explain why. I'm just telling that because this is a new guidance that was only from 2018, something considered to be new. Not all the people are aware about it. Okay, that now we are not dealing with what is called the STEMI and non-STEMI. We are dealing about occlusive MI and non-occlusive MI, and I will say why also. Okay, so yes, this patient need to be sent to the STEMI, but then to the primary PCI. Then would you start him on GTN spray and give him aspirin or not? What do you think? And when the GTN spray is contraindicated, when if you give the patient GTN, that patient can die.
So GTN, oh, this patient, if we keep giving the GTN, it will not, because it will not work. He's got a complete occlusion, so he's not having.
Yeah, with you, but there is still you need to give a GTN in patient having a STEMI, isn't it? In patient having complete
Yes, but
occlusion, you need
how
to give
long?
GTN to get to decrease the pain. Okay, yeah, it might not help with the ischemia, but it will decrease the pain because it will make some vasodilatation in the arteries. So, but when the GTN spray is contraindicated, because that's important, this patient will go through the ambulance to the other hospital, have 1 hour drive to reach the hospital, and then when if you give him GTN, you will kill him, and when you will give him a GTN, that might save him.
I don't know the contraindication, but as
Yeah,
soon as the morphine we can give, I think we need to give
okay.
the morphine
Yeah,
with
that's sure
antiemetic.
that if you have it, yeah, if you have the capability of inserting cannula and give him IV morphine or oral morphine and antiemetic, yeah, that's well and good. Giving aspirin for sure if there is no contraindication, if he doesn't have history of bleeding or ulcer or yeah,
Mm.
for sure you can give him. But if the patient have any symptom, and this will discuss it over, ongoing weeks, because we cannot cover the type of complete occlusion and non-complete occlusion in one go. Okay, I will discuss every day one, or every week one category. Okay, so if the patient have right infarct, yes, right ventricular infarction, you can't give GTN spray, and the leads that is looking at the right ventricle is V1. Okay, V1 is directly looking at the, at the right ventricle, and there is some elevation here. So is it true infarct or not, or is it only septal infarct? We need to do another ECG with AV4, isn't it? So the V4, instead of putting it in the left side of the chest, you need to put it in the right side of the chest, so you can see directly, looking directly on the right side of the heart to see if there's infarction there or not. And if you find elevation in AV in the right side, V4, this means that the patient have right-sided infarction. You cannot give him GTN spray, otherwise he can die, because the right side of the ventricle, or the right ventricle, depends on the preload. Okay, depends on the filling, depends on the venous return. And once you give GTN spray, all the venous system will start to be dilated, and the venous return will decrease, and then the cardiac output will deteriorate more and more. So so that's why when you said I will do the posterior leads, I was happy. I thought you will say also I will do the right leads. So it's not only 12 leads, by the way. We have something called posterior leads, and we have right leads, which you need to read about them, and and might, because you might need to do them in your clinic. Okay. But the other thing in this case, then they find, you know what is the STEMI equivalent?
What
Yeah, Dr.
is to
Rahima?
me? Yeah.
STEMI equivalent. So the old classification, it was STEMI or non-STEMI MI. Okay, the STEMI is the classical when there is elevation of the concordant lead, and then we'll explain what is concordant leads. Okay, and then we said, okay, but sometimes the patient will have some ECG changes. Yeah, it's not STEMI, but it's also indicative of complete occlusion, and that's why if the patient have new onset right bundle branch block, we was sending him to the cath lab, isn't it? This is one of the indication of cath lab activation. If the patient have posterior MI, well, in the 12 lead ECG, you cannot see ST segment elevation, the posterior MI, but if you did the posterior, you can see them, but still weak. If you have, tall R wave and ST depression in V1 and V2, you will still make, start to activate the cath lab before doing the posterior leads. So then they said, okay, then this is not the right, not the right name. So we will remove the STEMI and non-STEMI. We'll make it complete occlusion, non-complete occlusion. And then they said, okay, the complete occlusion MI, we will do, activation of the cath and non-complete occlusion MI is the one that will benefit only from delayed stenting. Okay, and one of the pattern of complete occlusion. Okay, what is called Aslanger pattern. So what is Aslanger pattern? Which is completely easy to be missed. Okay, there's an isolated rise in lead 3 in the IVF. Okay, in the lower leads. Okay, so lead 3 in the lower leads, isolated rise or accompanied rise between V1 and V2. But the rise of the ST segment elevation in V1 should be more than V2, and then ST segment depression in the rest of the chest lead, so V3 or V4 or V5, keeping in mind that T wave should be positive. Okay, so this is an indication of activation of cath lab and primary PCR because this is indication of complete occlusion. Is that clear?
I'm not, I'm just, when we say complete occlusion,
Uh-huh.
so where we think is a left bundle branch fully blocked, both left and right?
No, I didn't say that this is a left bundle punch. I didn't get the question.
No, so which artery is
Which
completely
art
blocked?
now? Which art? Okay, so they find this is specific pattern. This is a specific pattern. Okay, they find this is a specific pattern of ECG caused by multi-vessel occlusion. Okay, they will have most probably three vessel occlusion, not
Okay.
only one. And that's but the inferior lead, the inferior or the right coronary, okay, will be more affected than the other. Okay, and that's why it's important this button because if this patient came to me when in a coronary angio cath lab, okay, when we are entering with the catheter, okay, we need to know which artery we need to open it first, okay, and usually we will open the artery that is closed more first, okay,
Hmm.
to prevent the infarction from progressing. So we are giving a lot of dye and see which artery is passing, little dye than the other, and most probably we can do that mistakenly. Okay, so because judging how fast is the dye is with the eye usually is not accurate. Okay, so they predicted with this pattern, okay, of ST segment elevation isolated in lead 3 that most probably the right coronary, yeah, it's multivessel disease, but the most affected is the right coronary artery. Okay, and I will show you why it's giving this specific pattern. Okay, because the vector is taking toward the lead 3 when the RCA are blocked, and I will show you in a diagram. Okay, is that
Yeah.
clear? A
Yeah,
little
thank
bit.
you.
Okay,
Yes.
no, no, stay with me. Don't go. Still, there is a
No, no,
lot to
no, no, I'm
discuss.
okay.
Okay, yeah,
Yeah.
stay. Okay, so this is are the criteria of Aslinger pattern. Is very new pattern. Okay, it was only introduced, at the beginning of 2018. You won't find a lot of people know about this information. So it's very good from you guys to try to disseminate it and try to spread the knowledge. Okay. So why exactly this? pattern will appear, because when the RCA are blocked, okay, in the presence of multivessel disease, you can see the vector will go, the vector of the electricity of the heart will go toward the right, toward the lead 3 and AVR. Okay, you can see that.
Yes.
Yeah, are you aware about this picture, how the vector are calculated and how we are calculating the axe? I think you are aware. No?
Yeah, axis.
Yeah,
Yeah.
yeah,
Yes.
exactly. So usually the normal axe of the heart will be towards lead two, okay? And
Mm.
that's why lead two will have always positive R waves, okay? And also most probably the B waves in lead two is the best where you can detect it. So if you have any ischemia, that will shift the axis toward one of the leads, okay? And if you have multiple ischemia, and specifically in the right RCA, that will shift the axis towards lead 3 and AVR, okay? But specifically toward lead 3, and that's why you will have isolated voice in lead 3, okay?
Mm. Mm.
Yeah.
Yes.
So
Thank you.
yeah, no problem. So coming back, what this was your question, which artery was specifically occluded, and then that will bring us to the old classification. Okay, so if unstable angina, usually it will be minimal occlusion, and there will be no necrosis, and you will have is T wave inversion. But in non-STEMI, you can see the occlusion is nearly almost all the lumen, but will be very small tunnel that can pass the blood, and then that will give a chance to the collaterals to start, okay, and that will give us only ST segment depression, but because it's what's called submural infarction, so there will be part of the muscle fibrosed and part of it still there is a muscle, and then this will change the way of the electricity movement, and that's why that will give it an instant segment depression. I think in another series we will discuss in details how the why these changes is happening, but this will need a specific series for the ECG, and I promise I will do it. Okay, but in the future, not now. But the complete occlusion of the coronary artery will give us transmural necrosis, and that will give us, the shape of the ST segment elevation. However, transmural necrosis, okay, can happen without this elevation of ST segment elevation, and with other specific patterns that we will take it every week. Okay, one of them is the pattern that we take it today, so keep knowing it, and then the other pattern will take them in the other weeks. Okay, coming back to why we have 12 leads. So, what is the importance of having 12 leads? Why it's not three? What is not two? Why is not six? So what is the importance of having 12 leads? So every leads in the ECG is looking at the heart from different angle, okay? And it's like camera that's looking at the heart in different ways to surround the heart in three-dimensional space, okay? And that's why each change in each of these camera can reflect part of the heart, okay? So usually the inferior lead, so the lead that is looking at the inferior of your heart is lead 3, 2, and AVF. And then, hello? Yeah?
Yes. Yes. Two,
Yeah,
three
yeah,
ABM.
yeah.
Yeah.
These are the one that is looking at the inferior part of the heart. So if you find any elevation in these part, usually this is in the inferior part, okay, and usually it's supplied by the right coronary artery. And then you have the lateral and the anterior lead. So V1 and V2 are usually looking at the septum, okay, and V1 and AVR are looking at the right side of the heart. I think with this diagram the things are more easier, okay, but then V4, V5, V6 are looking at the lateral side of the heart and the anterior, okay. And adding on them the limb bleeds, that one and AVL also looking at the lateral side of the heart. So according to the changes in each of the concordant leads or anatomically concordant lead, you can suspect which part of the heart is affected. Okay. And that maybe will be clear in the next slide. Here is also the category of, which part of the heart are supplied by which. So the
Yeah.
right side of the heart by the right coronary artery, okay, the left side of the heart is by, the anterior part is by anterior descending or the LAD, okay, and the lateral wall is by the circumflex artery. Also, why that is important for us, okay? Well, because it's according it, when you do the cath lab, you will know which artery you will go to open it first, okay? So localization, that's important, the importance of localization, okay? And as well as you don't want to miss something like that, so you need to know the pattern of each categories, okay? Coming back to categorization, you can see here 2, 3 AVF is in the inferior lead, and then the lateral lead will be V5, V6, or higher lateral leads will be V5, V6, 1, and AVL, and that will be easier if you remember the diagram, okay, of the ECG leads. And then the septal lead is V1, V2, but please, please, please don't forget that V1 and right V4. Right V4 is looking at the right side of the heart, and specifically you will need that if you find ST segment elevation in V1. So if there's V1 ST segment elevation, you need to do the right side of the heart, the right lead, V4 right lead, to make sure if this patient have right-sided infarction or not, because with the right-sided infarction, you don't need to give GTN because you can kill the patient, okay? And this is summary of all, the topographic appearance of the heart on the leads and the blood supply. Um, Not sure. Is that clear or was difficult?
Yes, it is clear. Just one thing that if it is right side, so
Okay.
that means inferior MI.
No, yeah, that's good that you said, because inferior MI can come with right-sided infarction or not. Okay, so it's not always okay, because it depends on what, sometimes the right side of the heart, okay, will be having additional branches coming from the left circumference.
Yes,
Okay,
yes.
so not all inferior MI will be accompanied by right infarction. Okay, because they may get some additional blood supply from the
Blood
left
supply.
circumflex. Okay,
Mm.
so how to differentiate? So if you have isolated rise in V1, do the AVR, okay, because maybe it's isolated only right infarction. And with every inferior MI, I would do the right-sided leads because I need to know, is this inferior MI combined with right-sided infarction or not? If you find the raise in V1 and right-sided V4, then that's accompanied with right-sided infarction. If not, so it's not. So with the inferior MI, you can give the GTN if you clear the V4. If you didn't clear the V4, then it was not clear and there is elevation, I will avoid giving the GTN spray because that can kill the patient.
Mm.
So as you said, so with every V1 ST elevation, you will do the right lead. With every inferior MI, before giving the GTN, I will do the right lead to make sure that he doesn't have a combined right-sided infarction.
Thank you. Yes.
Yeah? Is
Yes.
that clear? I hope it's clear. I know it's a little bit confusing, but by getting first, I know that you have your past experience of emergency, so this will not be difficult for you. But for the other doctors, I'm not sure if that's confusing or not, but I promise that the things will become clear as we go through the other series, okay? And the key point that I want you to not forget from this discussion is this photo, okay? Because it will make sense later on. And the other thing is this button, the Asgler button. Okay. Yeah, the Aslanger pattern, okay, which is ST elevation in lit 3 and then ST depression in V4 to V6 with ST segment elevation in V1 more than V2. Yeah,
Yes. Mm, thank
yeah. Let me just stop the recording, or if someone can stop the recording because I don't know. My computer is stuck. Let me see. Does anyone have any question, doctors?
Yeah, I do, Dr. Salem.
Yeah, please go ahead.
Thank you so much for the
No
presentation.
problem. No problem at all.
I was just wondering